and they're out of the University of Washington and Dr. David Spock, and they're really great resources. So we have a lot of things to cover today. So again, I think the theme of today has been maybe an overview of a lot of topics, but today what I want to talk about is I want to review an approach to HIV prevention with pre-exposure prophylaxis, or PrEP. Then we'll review approaches to and updates in HIV treatment, and then we'll go through some rapid fire updates in the world of sexually transmitted infection. So let's start off with prevention and PrEP. So some of you and many of you may be familiar with the Ending the HIV Epidemic Initiative, or EHE. This was announced by the Department of Health and Human Services in 2019. And the goal was really to reduce the annual number of new HIV infections in the US by up to 90% by 2030. So a lofty goal, but I think one that we all thought could be achievable. And one big cornerstone of EHE is using PrEP, or pre-exposure prophylaxis. So what is PrEP? So it's a prevention strategy in which a person who does not have HIV, but who is at risk for HIV exposures, takes a medication regularly to prevent acquiring HIV. And currently there are 3 medications that are FDA approved for PrEP. And some of these drugs you may be familiar with. Some of them, actually all of them, are components of HIV treatment regimens as well. And we'll talk about treatment a little bit later. But our 3 options, the oldest is daily oral tenofovir disoproxil fumarate emtricitabine. And I'm going to say, pardon me for all these names if you're not familiar with them. They all have brand names as well. So this is TDF-FTC, or is an abbreviation, also Truvada. That was approved in July of 2012. Our second option is daily oral tenofovir alafenamide emtricitabine, or TAF-FTC, brand name Descovy. That was approved as PrEP in October of 2019, but really notably not for persons who have receptive vaginal intercourse. And we'll talk about why a little bit later. And then finally, the newest, hottest thing on the market, and I think there was a booth next door, injectable cabotegravir, or Apretude, given every 2 months as PrEP. That was recently approved in December of 2021. And so why PrEP? So if we look at the estimated number of persons with a need for HIV PrEP in the United States, this data is a little bit old, but 2021, about 1.2 million people could benefit from PrEP. And only about a quarter of them were actually receiving PrEP. And on top of that, as we see in all of healthcare, but especially I think in sexual health, there are a lot of inequities in distribution. So that's true by race, ethnicity. So Black people and Hispanic and Latinx individuals are underrepresented in PrEP prescriptions and overrepresented in new HIV diagnoses. By region, the Southeast United States has the highest rate of new incident HIV diagnosis, and again, lowest prescriptions of PrEP. And then by gender. And so when we think about populations that are most effective, transgender populations, specifically transgender women, are most impacted in terms of incident HIV infection. So these are really areas where we need to try to be getting HIV PrEP to people. So what are the CDC indications for PrEP? So this chart is kind of a summary of the guidelines in terms of who we should talk about PrEP with. And it's divided among men who have sex with men, or MSM, heterosexual men and women, and then PWID is its own category of people who inject drugs. And so you can see is for all of these groups, having a partner with HIV, having been diagnosed with a recent bacterial sexually transmitted infection, having multiple sex partners, having condomless sex, exchanging sex for drugs, money, or other resources, and in the case of people who inject drugs, sharing injection equipment. All of these things qualify a person for PrEP. And the other caveat that is in the guidelines that I think is really important to note is that if someone comes to you asking for PrEP, you should probably give PrEP, because these are really stigmatizing conversations. They're stigmatizing things to say to your doctor. And if people are asking for PrEP, they are usually trying to ask for something that they think and know they need. So that being said, who can we prescribe PrEP to safely, and how do we think about counseling? So there's a lot of conversations that happen around this, but one thing I really want to point out is comorbidities in PrEP. And so who is safe to get these? And the answer is really most people. Things to consider, Truvada, or TDF-FTC, is contraindicated in people with a creatinine clearance of less than 60. TAF-FTC, or Descovy, is contraindicated with a creatinine clearance of less than 30. And you can see is, what I hope I'm pointing out is there are 2 formulations of tenofovir. Disproxyl fumarate, which is a little bit older, and is a little bit more renal and bone toxic. And then TAF, or tenofovir alafenamide, is a little bit less renal and bone toxic. For anyone whose renal function is worse than that creatinine clearance of less than 30, then IM cabotegravir, or CAB, I don't think I've used that 3-letter abbreviation yet, but lucky you, now you have another one, for patients with significant renal disease in whom we cannot give tenofovir. And I mentioned bone already. If people are at high risk for osteoporosis, consider a bone scan and think about asking a bone health specialist or endocrinologist before giving any form of tenofovir. But in general, we think of TAF as being more bone-friendly than TDF. If there are any contraindications to tenofovir use at all, use cabotegravir. If there are contraindications to all three, unfortunately, we have no other options for PrEP in terms of a pharmacologic intervention, but there are still a lot of discussions to be had about harm reduction techniques. And so how else do we counsel beyond these comorbidities if we've decided we're going to give these options? So for oral PrEP, Truvada or Descovy, there's a few side effects to think about. The most common one that we find, and this is true when we're using it as part of a treatment regimen and as part of PrEP, is that there can be a startup syndrome of kind of GI, stomach upset, intolerance that usually passes over a week or so, and often we'll prescribe things like Zofran to help people through that first week. In terms of renal side effects, we already talked about that creatinine clearance can decrease slightly by an average of about 2.5% over 18 months. Bone density can also decrease by a very small amount, but it stabilizes and is reversible with discontinuation with no direct increased risk of fracture. So what we're getting at is these are really quite safe medications. In terms of injectable PrEP, IM cabotegravir has a Q2-month intramuscular injection. I'll say that this is not something you're doing at home. This is something people are coming into a clinic facility for injection so far. Side effects are really injection site reactions, not much else that's been reported, and people can just apply warm compresses to the injection site and take pain meds if they are having issues with that. In terms of indications and the recommended use, this table I think is a nice, although busy, way of categorizing who we can give all of these PrEP options to. So for cisgender men who have sex with men or women, any of these options are acceptable PrEP options. For trans women, that's also true. The one caveat is cisgender women who have sex with men. And you may remember that maybe a few years ago when Descovy or TAF-FTC became approved for PrEP, there was a little bit of controversy and a lot of headlines about why can't women have this? And the reason is because that approval trial, the trial that led to approval, the Discover trial, didn't actually evaluate its efficacy in women as PrEP. And the reason, there was a lot of discussion about equity, but the reason that the drug companies didn't go after this, or the reason we didn't investigate this, is pharmacokinetically, there are concerns about TAF achieving appropriate concentrations in vaginal mucosa. So as a protective mechanism, that's something that hasn't been really tested well, and not something we can recommend for people with having vaginal intercourse. For people who inject drugs similarly, the data we have is for TDF, FTC, or Truvada. It's not FDA indicated, but we use it, we recommend it, and that there's some trials, most famously the Bangkok tenofovir trial, that does show decrease in incident HIV in that population. We'll talk about on-demand PrEP in a little bit, but the only drug option that we have for that is TDF, FTC, or Truvada. For adolescents, this is weight-based, so if you're greater than 35 kilos, fine. And then we talked about renal dysfunction already a little, that TAF-FTC is okay up to a creatinine clearance of 30 coming down. CAB is safe at all renal clearances. All right, and then functionally, maybe you've decided, okay, we're gonna do PrEP today, and we've even picked one. What do we need to do in terms of lab studies before starting PrEP? So there's a few tests that everyone has to get. There's a few that only some people will have to get. So everyone has to get the HIV 1,2 antigen antibody assay. We've also referred to this as the 4th-gen HIV screen. And that's because we just have to know if someone has HIV before we start them on PrEP, because PrEP is a component of a full treatment regimen. And that's true of all of our options that we're going to give. For those getting intramuscular cabotegravir, They should also get an HIV-1 RNA or a viral load. And that's important for reasons I'll talk about during treatment, but really have to do with risk of resistance developing and really needing to know if someone has acute HIV at that point. In terms of renal function, we've gone over this now a few times. We need to know it for the tenofovir-based regimens. For TAF-FTC, we need to get a lipid panel because there is a slight deleterious impact on lipids with the TAF formulation. And for everyone, we need to know on a TAF-based regimen or TDF-based regimen, we need to know their hepatitis B serology. This is really important, and this will become a theme in HIV treatment as well, because tenofovir is a hepatitis B treatment. Emtricitabine and lamivudine, so we've talked about emtricitabine, and then lamivudine is very similar, comes up in treatment options, also can be active against hepatitis B, but has a very low barrier to resistance. So the hepatitis B virus can mutate very quickly. So we really, really want to know if someone has hepatitis B. And the other problem is when you withdraw tenofovir in someone with hepatitis B without knowing, they can develop a reactivation of their hepatitis B, and in the worst cases, acute liver failure. So it's really important to document that. Everyone should get hepatitis C testing, and everyone should get bacterial STI testing. In terms of follow-up labs, now we divide this into oral PrEP, so our Descovy and Truvada options versus our injectable. So for follow-up every 3 months, we get an HIV screen again. In the guidelines, but I think controversial, and I will say something I do not do in practice, is getting an HIV viral load every 3 months for oral PrEP. That is because it is an expensive test with a long turnaround time, and functionally, most clinics aren't going to be able to take that cost. I'm happy to talk a little bit more about that if there's time at the end. Everyone should get a serum creatinine yearly. That can be every 6 months if someone has risk factors for worsening renal function. So greater age or a lower creatinine clearance. Hepatitis C testing in these populations should be done yearly. The lipid panel we talked about yearly for TAF-FTC, and then screening for bacterial STIs every 3 months. On cabotegravir, the intervals are a little bit different, and they're timed mostly towards the injection times. So HIV testing now has the 4th gen and the RNA. Here, the RNA is not controversial. It's because it is much harder to diagnose HIV in people on an integrase inhibitor, this class, and we need to know, again, if there is emerging HIV infection in that, and those treatment failures take longer to diagnose and have implications for treatment. Hepatitis C testing, again, every 12 months, screening for bacterial STIs every 4 months, and that's not because there's anything different about people on cabotegravir than on oral PrEP, but it's just because if they're coming back every 2 months, why make them come back in between for a 3-month follow-up STI screen? I do want to make the point, especially because I said that in the indications for PrEP, having a partner with HIV is an indication for PrEP. I do want to make sure, and I think many of you know this, or most of you know this, there is this really important concept in HIV of undetectable equals untransmittable, or U equals U. And we know that an individual with an undetectable HIV viral load, someone who has HIV, is on treatment for HIV, and is undetectable and suppressed, cannot transmit HIV to their sexual partners. And it's not very often in medicine that we get to say something so definitively, but I think it's really important to state this. And we have a lot of data among heterosexual couples, among men who have sex with men, and a lot of kind of person years and condomless sex acts with no incident HIV infections that were phylogenetically linked, meaning that the HIV strain that anyone did pick up, if they did end up having HIV, was not from their partner. And so I think when we counsel, that's really a lot of shared decision-making. Some people, and I have some patients, I think we all have some patients who are really, really anxious, and would make them feel better and more secure in their marriages, their sex lives, the way they conduct their lives if they were on PrEP. Some people are really relieved to not have to take another pill. What about HIV infection while taking PrEP? We'll move on to this a little bit in the treatment section, but I just want to point out when you're counseling, seroconversion does occur in about 3% of people taking PrEP, but most of these failures are really due to poor or incomplete adherence, so not taking the PrEP every single day. Some PrEP failures are from undiagnosed HIV prior to starting PrEP, which is why we test for it so regularly. And then there are rare cases of transmitted resistant strains of HIV, meaning someone getting an HIV strain that was resistant to a component of PrEP. And what do you do if you suspect PrEP failure, or you have a patient who is on PrEP who now has HIV or tests positive for HIV? Repeat all your testing, so your HIV antigen antibody screen, the viral load, and a genotype, which we can get into a little bit later. There is something called the CCC PrEP line. That's a warm line, so you can talk to someone in real time, and then start antiretroviral therapy immediately while on failure while on oral PrEP. And we do have the CDC PrEP guidelines as a resource, and I think soon to be online officially, UW will also have an online PrEP curriculum. I do want to make a point about on-demand PrEP, which I touched on earlier. This is not FDA approved, but it is in the CDC guidelines. It is not recommended, but it is just described, is the wording I would use. So some people say, gosh, it is really, really hard to take a pill every single day. And I know when I'm going to have my high-risk exposure or risk exposure. I know, and people will say this, I'm going to go on a weekend trip to Palm Springs, and I'm going to have a bunch of sex. And that's great. And they don't want to take a pill every day until then. So we do have data from sub-studies of some of the French PrEP trials that taking something called on-demand PrEP, and again, this is just TDF, FTC, or Truvada in men who have sex with men. And the idea is you take 2 tabs, 2 to 24 hours before sex. You have your exposure event, 1 tab a day after, 1 tab 2 days after, and that's your 2-1-1. And the idea is if you take the 2 pills, you get the concentrations you need to prevent that acquisition of HIV. If you keep going, then you just keep taking it daily. And if you stop and then start again at 2-1-1 next time this happens. The counseling, I would say, for this is we know this is pretty efficacious. It's not as high efficacy as daily oral PrEP. There was recently a study that got published that showed that this was actually not as great as we thought. But if you look at the data, it looks like people weren't taking it appropriately. And so I think for all, it's like all medication, it works if you take it the way that it's supposed to be taken. Daily oral PrEP, we know, has higher success rates, but this may be a really good option for some individuals who have the kind of situation I described. And resources for PrEP, there's of course the 2021 CDC guidelines. There's the National Clinician Consultation Center PrEP warm line, and then the USPSTF PrEP evidence summary, which I should plug, I think just in the last week got updated to include injectable cabotegravir as a PrEP option. So CDC already had it as of December 2021. USPSTF has now just added that to the summary as well. So take-home points for PrEP, we have 3 options, 2 that are oral, Truvada, TDF-FTC, or Descovy, TAF-FTC, and then 1 long-acting injectable agent, cabotegravir, which is Apretude or CAB. PrEP should be offered to anybody at risk for HIV, including all the things I listed, and most people who asked for it. And then there's a lot of various comorbidities and patient populations to think about when picking your PrEP choice, but I think having that table and the guidelines to refer to can be very helpful in that scenario. All right, so now we're going to shift gears a little and talk about HIV treatment updates. So I want to point out, and I really like this slide that a colleague of mine has, that ART then versus ART now. So antiretroviral therapy used to mean a lot of pills, a lot of toxicities, hard to tolerate. And now I have an old co-resident who's a cardiologist who I was on the phone with, and he said, why do you want to do this? Just give them Biktarvy. And I was like, okay, it's a little more complicated than that, but the idea is still there. There are many now 1 pill once a day options, and that's really, really exciting for our patients. So that being said, there's still a lot of options that are beyond those 1 pill once a day options. And this is a nice chart that the AIDS Education Training Center has come up with that looks at all the different kinds of medications that are out there. So, and what I'll say that the other thing that's changed in the more modern ART era is that antiretroviral therapy is recommended for all persons with HIV, and that's to reduce morbidity and mortality, and also to prevent transmission of HIV to others. And this should be happening as soon as possible after diagnosis. And so that's a little bit different in the last decade or 20 years than what it used to be like. I said this was going to be updates, but I think it's always very, very helpful to think about where our drug targets act in HIV. And I think this is my favorite part of all of infectious diseases, is thinking about the HIV life cycle and where our drug targets act. So the first part is viral entry, where we look at entry, attachment, and fusion. There are drugs that act there, but those are part of what we now call our deep salvage regimens. We're not using these as standard of care therapies right up front. I have kind of in non-italics what we do use. So the next step after attachment, entry, and fusion is reverse transcription of the viral mRNA. And then here we have in that process 2 drug targets, so NRTIs and NNRTIs, so the non-nucleosides and then the nucleoside and nucleotide reverse transcriptase inhibitors. After transcription, that double-stranded DNA gets integrated into the host cell DNA, and that step, integration, is blocked by integrase strand nuclear transfer inhibitors, or INSTIs. You may have heard just integrase inhibitors. All of those are correct. Next, we have transcription, translation, and then we have this nice polyprotein chain that's been made in translation where protease acts to have cleavage and assembly, and that's where protease inhibitors, which many of you will remember was kind of the game-changing ART class back in '95. So when we build a regimen, now in the modern era, the principle is really we have a 2 NRTI backbone, and then we can add one of the 3 other classes I talked about. So NNRTIs, PIs, or INSTIs. And our principles of choice are a lot of things. So potency, how fast does the drug suppress the virus? Barrier to resistance, how easy is it for the virus to overcome and mutate over that drug? How tolerable is the drug and what are the side effects? What starting CD4 count and HIV viral load is the patient at when we're starting? What is the formulation and the ease of taking the meds? So we talked about single tab regimens or STRs. There's also multi-tablet regimens or MTRs, and now injectable regimens. How frequently do they have to be taken? Has this person been on ART before? Do they have drug resistance from prior? And unfortunately, we do always have to consider cost. So this has gotten a lot easier, though, in principle for most people. And so this is most people with HIV from the HHS antiretroviral therapy guidelines in 2022. So if someone has not been, or is antiretroviral naive, so has never been on ART before, and has not gotten injectable cabotegravir for HIV PrEP, but they may have been on oral PrEP, then you're going to have your anchor drug be the integrase, and then the other drug, will either be the 2 NRTI backbone that we talked about, or, and I just told you about 3 drug regimens, but now that we also have 2 drug regimens, so can be 1 NRTI. It's always a caveat to the rule. So these are the START guidelines fully. So these are our actual options. So I told you the breakdown. And so that first pill is Biktarvy, is the brand name, bictegravir, tenofovir alafenamide, and emtricitabine. And I hope some of those drugs sound familiar because they were part of PrEP. So the 2 NRTIs and the oral PrEP options. We also have dolutegravir, abacavir, lamivudine, which is called Triamec brand name. The caveat here is you do have to send some testing that can be a little annoying. So an HLA B5701, because people who have that HLA type are prone to abacavir hypersensitivity reactions, which can be life-threatening, and having that type is a contraindication to ever being on abacavir. They also cannot have hepatitis B because, as I just reviewed, tenofovir, you really need tenofovir in your regimen if someone has hepatitis B. And then in terms of multi-drug regimens, that could be first line. We can have dolutegravir plus either TAF-FTC, Descovy, or TDF-FTC, Truvada, or TDF lamivudine, which we don't really see in the US, but you may have patients who are coming from especially Africa and parts of Asia who are on a drug called TLD. That's a 3-drug single tab regimen that is produced there. That is TDF, lamivudine, and dolutegravir. So again, the principle is really 2 NRTIs, an integrase inhibitor. And then we have one exception for the START regimens. That's a 2-drug regimen, and that's dolutegravir, lamivudine. So 1 INSTI, 1 NRTI. Again, there's some caveats. So this is brand name Dovato. This was approved only for those who at diagnosis have a HIV viral load of 500,000 or less. And that's just because we're worried about the 2-drug risk of mutations at higher viral loads. Again, we need to know if they have hepatitis B, and importantly, we have to send an HIV genotype. And I said I'd get back to this. And the idea is that we can sequence HIV for resistance mutations. And so there's 2 lab tests you can send. One that sequences the reverse transcriptase and protease portion of the HIV genome, and one that sequences the integrase. I don't know why they can't all be one test. It's just one long chain, but that's what happened. So you have to send the RT-PI genotype before starting dolutegravir lamivudine, because again, it is really important to know that there is no resistance to the lamivudine in a 2-drug regimen. It just gets way riskier than when you're doing a 3-drug regimen for this. What to start if you've had PrEP? You know, I think it gets a little more complicated if you've been on Apretude or cabotegravir as PrEP, because that is in the integrase inhibitor class. And so now if someone breaks through on that, we're a little bit worried that they've developed integrase resistance. So if someone has been, again, not on cabotegravir, but on oral PrEP, we can just get a standard genotype, but you can just start any of the regimens I just listed except for the Dovato. For those who have prior cabotegravir, though, we have to get both genotypes. You start a different kind of regimen with the protease inhibitor as the anchor, and then switch to an integrase. And again, I think the big principle here is it gets more complicated if they've been on cabotegravir as PrEP, and you should probably talk to an HIV specialist or infectious disease doctor at that point. And so what about our other 2-drug regimens? I told you about Dovato. That's the only one that's in the START regimens, although with caveats. Another one you may have seen is Juluca or dolutegravir rilpivirine. Rilpivirine is an NNRTI. People need to be virally suppressed if they're starting this. They cannot have hepatitis B. They need that RT-PI genotype. And the other thing is that it's a really compelling drug to use. I just would exercise some caution. You know, people use it a lot in people with renal dysfunction, for example, because there's no issues with creatinine clearance. But rilpivirine is a finicky drug. It needs a perfect stomach pH to be absorbed optimally. It is contraindicated to be taken with PPIs, and I don't know about you, but the majority of my patients are on a PPI. If they're taking even an H2 blocker, it has to be separated by 12 hours. So that is a lot to ask of someone. And then in the renal scenario, for example, we see a lot of patients on things like bicarb, right, or phos binders, which might interfere with the absorption of the integrase in that case. So I would just be very careful, but it could be a good option for certain patients. And then finally, we talked about cabotegravir as PrEP. We also have cabotegravir and IM rilpivirine, so IM co-formulated as Cabenuva. Again, for now, people need to be virally suppressed if they're starting this. They cannot have hepatitis B, and again, you need both genotypes, but this is again a long-acting injectable regimen, which is really exciting. And I should say that the IM rilpivirine means we avoid any issues with stomach absorption that I just warned you about. So this is just a little bit more about the indications for cabrilpivirine. It is the first extended injectable complete ART regimen in the US for people with HIV. It's a switch regimen still, so you have to be suppressed. Not as an initial regimen, no history of treatment failure, no Hep B. We don't have enough data in pregnancy, and think about drug-drug interactions as you would do with any of these regimens. So take-home points for treatment. Anybody with HIV should be offered ART as soon as they are diagnosed if they are willing to take it. Our standard of care therapy includes a dual NRTI backbone in still the majority of cases, I would say, and an integrase anchor. 2 drug regimens are increasingly utilized options, but just again, exercise caution. And then the new frontier of ART is really these long-acting injectable options, currently Cabenuva. Some of you may have heard also about lenacapavir coming out for very resistant HIV, and that's a Q6-month subcutaneous option, which I didn't even get into. But I think this is where HIV treatment at least is moving, and it's a really exciting time to be involved in it. Okay, so finally, I'm gonna end with a rapid review of sexually transmitted infections. This will obviously not be comprehensive, and I'm focusing a little bit on updates in recent guidelines. So why talk about STIs? I think everyone knows that all STIs, chlamydia, gonorrhea, and especially syphilis are rising across the country, and they have a disproportionate effect on certain groups. So adolescents and young people, gay, bisexual, and other men who have sex with men, pregnant people, and then some racial and ethnic minority groups. And I think this is what this flyer from the CDC is really, really dramatic. I mean, a 200% increase since 2017 in congenital syphilis. It's pretty unprecedented and really unfortunate. And I think the other thing to point out is that there's concomitant substance use issues as a risk factor. And I think when we talk about syndemics or twindemics or things that are going on that affect our patients, that I think many of us are seeing the impacts of substance use. And I think we really have to think about STIs as something that is a concurrent and related epidemic. So that being said, let's talk about some of the most common bacterial STIs. So chlamydia is the most common STI in the US. Impact on women left untreated, it can cause pelvic inflammatory disease, a lot of pain syndromes, infertility. Other syndromes include trachoma, anogenital infections, LGV or lymphogranuloma venereum, and conjunctivitis. It's diagnosed by PCR. Screening recommendations vary by group, but most people should be screened, notably young women under 25 who are sexually active. What's new in the guidelines? Not really much, actually. So it's still recommended that doxycycline twice a day for 7 days is the recommended regimen, especially for rectal infection. That's where we know it is superior to the alternative regimen of azithromycin. We can also think about levofloxacin. LGV or lymphogranuloma venereum, the difference is we treat for longer. So that's that kind of fistulizing proctitis form of chlamydia, different serovar. Gonorrhea, second most common STI. Again, a lot of syndromes, urogenital, pharyngeal, rectal infections, conjunctivitis, PID, infertility. The kind of special syndrome is disseminated gonococcal infection. Again, this is PCR diagnosed. Screening, again, I'll say varies by group, just because I think it's worth looking at the guidelines for this. There is some stuff that's new in gonorrhea. So there's been a lot of increasing concern over the last few years about antimicrobial resistance. And there have been rising minimum inhibitory concentrations, or MICs, to commonly used antibiotics, including azithromycin, cefixime, the tetracyclines, and even ceftriaxone, which is our standard of care treatment. So what are our changes in the 2021 guidelines? So ceftriaxone is now 500 milligrams IM for people less than 150 kilos. It used to be a lower dose, the 250. And again, this is because of those that MIC creep, so needing more drug to kill our bacteria. There is no longer a role for azithromycin dual therapy. If chlamydia has not been excluded, add doxycycline, not azithromycin. And then pharyngeal gonorrhea, there's this kind of, again, every guideline has something that we're all a little like, oh, why'd this come in? So for pharyngeal gonorrhea, the guidelines say treat, and then retest for cure in a couple of weeks. And the rationale is really that pharyngeal gonorrhea we know is the hardest form to eradicate. It is just really, really hard for whatever reason to eliminate gonorrhea in the oropharynx. The test of cure, though, can be functionally really difficult to get people back into clinic. Sometimes we don't know if it's old, dead, DNA or RNA. And so I think functionally many of us don't do this for asymptomatic gonorrhea and instead are doing quarterly testing for STIs in at-risk groups. Okay, and then last of the big three, and certainly not least, syphilis. So again, rising rates in the recent years in the US and really globally. And the impacts, I think, that are really relevant are chronic infection and then congenital disease. So syndromes, I could have had 10 slides on all the syndromes of syphilis. We know that it's the great pretender. But I think what's important is there's primary syphilis, secondary syphilis, which has a lot of the kind of protean manifestations, latent syphilis, and then which is asymptomatic and can be early or late, tertiary syphilis, which is the stuff I think we read about from books in the 1800s. And I should note that neurosyphilis, and I think this is a point of confusion for many people, can occur at any stage of syphilis. And so there's early neurosyphilis, so the ocular and otic syphilis forms, for example, that we've seen a lot of. And then when we think about tabes dorsalis and general paresis, that's really tertiary syphilis. We don't see that much anymore. But I think this idea that neurosyphilis can only happen at late stages is incorrect. Diagnosis, I just have the two algorithms. I'm not sure what every institution is a little bit different. At UW right now, we're using the reverse sequence algorithm where we start with the treponemal testing, move to non-treponemal testing, and then depending on that result, we'll have confirmatory a different treponemal test. What I used in residency when I trained on the East Coast was the traditional algorithm. So starting with the non-treponemal testing and then switching to antibody testing. So then how do we treat syphilis? So it depends on what kind of syphilis you're treating. So for primary and secondary syphilis, it's IM benzathine penicillin G, 1 dose. If it's latent syphilis, it depends on if it's early or late. For early, it's the same thing, 1 dose. If it's late, meaning that we either don't know how long this person has had syphilis, or it's been more than a year since they were last treated for syphilis, and we think you have a new infection, then we do one of those benzathine injections 3 times over 3 weeks. So once a week for 3 weeks. And then for neurosyphilis or ocular syphilis or otosyphilis, the standard of care is IV penicillin G as continuous infusion or every 4 hours for 10 to 14 days. The alternative regimen that we were using a lot in Seattle and at Madison Clinic was for people who couldn't be home IV antibiotic candidates or couldn't be inpatient. They would get procaine penicillin G and then take probenecid 4 times a day to keep their levels up. And they would walk in every day for this injection. Completion rates, you could probably guess, were not perfect, but still better than nothing. What's new in syphilis? Somehow we have run out of penicillin, kind of. So I don't know how the first antibiotic that we've used since the beginning, we can't manufacture, but bicillin, so benzathine penicillin, is on shortage. Procaine penicillin is no longer being manufactured as of this year. So now what? Now we're in the middle of a huge rise in syphilis and we don't even have penicillin. We do, just not enough. So the nice thing is we can use doxycycline, and Dr. Danaretti had talked about doxycycline, and we'd mentioned intolerability, which certainly is an issue, but it is an oral pill with honestly not that many side effects compared to many of the things we use. So for early syphilis, the recommendation is 100 milligrams twice a day for 2 weeks. For latent syphilis, we extend that to 28 days. And we're trying to preserve penicillin for those whom penicillin is the only option. So people who cannot tolerate doxycycline are allergic. And then I will really highlight this, pregnant people. It's really, really crucial that pregnant people get penicillin if they have syphilis. And I should mention that we are not out of aqueous penicillin G, the form that we use to treat neurosyphilis via IV, so we can still treat that, which is reassuring. And so just this last point about congenital syphilis, this is when there is T. pallidum transmission from a pregnant person with syphilis to the fetus. The risk is highest with primary or secondary syphilis. In 2021, cases of congenital syphilis increased by 32% and resulted in 220 stillbirths and infant deaths. There's different forms of congenital syphilis, early and late. I think we learn a lot of these in training. So rhinitis and nasal discharge, and late congenital syphilis, we talk about the saddle deformity of the nose. But to prevent this, all pregnant persons diagnosed with syphilis should be treated with penicillin with the formulation based on the stage. Those who have a true penicillin allergy need to be desensitized. That's it. That's the answer. I know I don't have much time left, but I just wanted to take one last slide to talk about DoxyPep. Has anyone here heard about DoxyPep, or has anyone used DoxyPep? All right, so DoxyPep, this is very, very new. So DoxyPep is the idea of giving doxycycline as post-exposure prophylaxis for the 3 big bacterial STIs I just talked about. And there was some preliminary data, and again, some of the PrEP sub-studies that looked at this and saw that people who were taking doxycycline after condomless sex acts actually had a reduction in their incident STIs. But that had never been formally tested in a randomized controlled trial. And so this is this is really nice because it was, for me, home-based trial. So this was 2 sites, San Francisco at UCSF and their public health clinic, and then Seattle at Madison Clinic where I practice, and the sexual health clinic. And what they looked at was saying, could you give 200 milligrams of doxycycline up to 72 hours after condomless sex among people who had had an STI in the past year? And this is specifically men, people who are male sex at birth, and then living with HIV or on PrEP. So there were 2 groups, and had had condomless sex with at least 1 male partner in the past 12 months. And they said, okay, what if we did this and looked specifically at what was the impact on STI, incident STI, and then they also separately, and I didn't highlight this, looked at drug resistance because they knew, because it was a bunch of infectious disease doctors, that that was going to be a big concern. And so they did STI testing quarterly, including syphilis testing. And what they really saw on that top is from the New England Journal paper that came out this past year. And we can really see that there is a significant difference in risk. And it's not separated out here in that first graph among people on PrEP and people with HIV, but a significant risk reduction. And then here in that second table, which I obtained from one of the investigators, Connie Kellum in Seattle, you can see that incidence of each of the STIs dropped. And I think this was really exciting for several reasons. One, people kind of expected chlamydia to drop. We know we use doxycycline to treat chlamydia, but chlamydia in men who are having sex with men is usually asymptomatic and I wouldn't say has the highest morbidity impact. But gonorrhea and syphilis, I think I just told you we're in a crisis. We have a shortage of penicillin. I think this is really compelling. And so I think there's been a lot of discussion. Every kind of new ID conference meeting has another discussion on it. But I just wanted to flag people that, at least the way I've been prescribing doxypep, is people who meet the inclusion criteria for the trial. It's at least a shared decision-making option. And again, we prioritize for people without HIV being on PrEP because we have a whole host of data that PrEP is effective and HIV is an infection we don't have a cure for. But there are some people who I think doxypep could be an exciting option. So the take-home points for STI updates: STIs are rising, especially in particularly vulnerable groups. There are updates and guidelines in the last couple of years, including higher dose ceftriaxone and gonorrhea. Unfortunately, penicillin formulation shortages may drive changes in decision-making around syphilis treatment, and we really should prioritize penicillin use for treatment in pregnant women in whom it is the only treatment option. All right, I know that was a lot of topics and not a lot of time, but happy to answer any questions.
My question is, Dr. Chua here. The HIV patient wants to get pregnant. So how do you advise them? And second, the use of ceftriaxone in CNS syphilis when they're pen allergic. What's your experience on this?
Yeah, both great questions. So the first, well, I just forgot the first one. I just remembered ceftriaxone, but
Pregnancy. And
yeah.
HIV discordant or concordant.
Right. So actually this has gotten, I was just talking to a colleague that this is one of those things that she was saying, this is much easier in your era of practice than it was when I was training. And it's true that the real principle of HIV and pregnancy is if a woman can be suppressed throughout the pregnancy, there is very, very little risk to the pregnancy in terms of transfer of HIV. We have a lot of data for that. And then we have a lot of good options for antiretroviral therapy. So any of the ones that I mentioned as first line are either recommended in pregnancy or, in the case of something like Biktarvy, are insufficient data to make a clear recommendation. But for people who are already suppressed on Biktarvy, we usually do shared decision making and say, if we know that being suppressed is better than anything, and we know this is relatively safe, so we can try it. So usually that's part of my preconception counseling. And the newer updates that I didn't bring up here are that chest feeding or breastfeeding, which used to be a hard no for any woman with HIV, are now shared decision making. So in the developing world, it was always, we think that getting any sort of nutrition to the baby is more important than any predicted transfer. In this case now, if you're suppressed, we'll say that it's okay to breast or chest feed. So those encompassed a lot of updates, but I think most important thing is stay suppressed. If you're not suppressed, get suppressed. And then the HIV guidelines have a nice table of what ART is contraindicated in pregnancy, what should be used with caveats, what should be dose adjusted. But again, for most of our first line therapies, we would just continue those anyway. So that
if the couple say they want to get pregnant, you just tell them go ahead.
Yeah, kind of. I mean, the usual preconception counseling and getting a little bit more frequent viral load testing, but it is a very, very different conversation than we used to have. And then with respect to your second question, ceftriaxone for people with syphilis as an option, it's a really good question. One, in the setting of penicillin allergy, short answer, yes, we've used ceftriaxone for people with penicillin allergies. And I think where this really comes up is in neurosyphilis. And so we have used ceftriaxone at higher doses to treat it. And actually right now, we are piloting Sexual Health Clinic and Madison using intramuscular 2 grams of daily ceftriaxone for the duration of a neurosyphilis course. And again, the idea is that in vitro, there's no reason that ceftriaxone shouldn't work. We have less clinical experience with it, but for people who that might be an option, we would use it. I still wouldn't use it in a pregnant woman, but otherwise I would try it.
Last question is on HIV patients that you're following their titer. To what degree of RPR do you follow them? Because 10 to 20% don't develop resolution of the RPR. What's your experience on that?
Yeah,
Because then you're kind of, we treated that patient and they want it to be 0, but
right.
so then it doesn't drop to 0. Then,
yeah. So what Dr. Chua is referring to, I didn't tell you at all about how we monitor syphilis RPRs and those titers and how we decide we've treated someone adequately. So generally what we say is that if someone's RPR, and if you've ever sent one of those, they'll come back reactive and then they'll come back with a titer. And it's literally someone diluting out, how long did it take before we couldn't see an RPR anymore. So they might start at 1 to 64 or 1 to 128. Generally, we say that to say that we've fully treated someone, they need to have a 4-fold drop in titer. And it depends in people with HIV or not without HIV, how long will allow for that to occur. For people with HIV, it'll be up to 2 years. For people, with HIV, up to 2 years. Without, we say a year, although it should be dropping earlier than that. But what Dr. Chua is referring to is this concept of serofast states. So people who never actually drop their titer all the way down. Most people will get to either it won't react or it'll just say reactive or 1 to 1, something where it's like, okay, that's fine. People with HIV have a higher tendency to remain having a detectable titer. And I think your question of how high do you, I think you're kind of getting at how high do you tolerate? I have some people who are hanging out at 1 to 16, 1 to 32, and it makes me nervous, but they really don't think they've gotten re-exposed. I've people, in my experience, my patient population is very, very frank about the sex they're having. And so I believe a lot of them. So I think that tolerance is a little bit thinking about what makes sense. Have I done a really thorough review for neurosyphilis? Because I think that's the other thing, that treatment failure often occurs in the setting of not really assessing whether someone has ocular symptoms or auditory or otic symptoms, and thinking about whether they need evaluation or a lumbar puncture to make sure that we didn't miss that. But otherwise, yeah, I think we all have some patients who are sitting on saying, I think we're living at this serofast state.
Hello, I have a question about vaccines, actually.
Okay.
So I know back after the COVID vaccine came out, the mRNA was talked about as a potential vaccine for HIV. Do you know if any of those studies are panning out, or if that still is something we don't believe is going to ever happen with HIV?
Yeah, I think that's a really, really great question. And I am not an HIV vaccinologist, but I know that there's been a lot of effort towards a lot of different vaccine technologies. People have been exploring mRNA vaccines. I think the tricky thing with HIV is how quickly it mutates and how even eliciting an antibody response from the way that we ask vaccines to do in us is really usually insufficient to suppress. And so I don't know any new data, but we're all excited for the possibility. And I think any technology, whether it's by injecting antibodies or by trying to get us to produce our own, is really looking at whether we could get multiple antibodies that are attacking the virus at different parts of its structure. Oh, yeah. So there was I think it was written on the slides and I didn't even talk about it. So for both IM cabotegravir as PrEP and then IM cabotegravir rilpivirine as Cabenuva, initially there was this issue about an oral lead-in. And so for most drugs, right, if we're going to give a long-acting injectable, we say it'd be ideal if we could see if you could tolerate the oral lead-in. That's now optional. And for most of the people I'm thinking about these injectables in, it's because they really can't tolerate pills, and I would hate to do that to them. And now we have so much safety data that says that we don't really need that oral lead-in that I haven't been doing it. I do have one patient who said he wanted to try the pills first just to make sure, but otherwise I'm not pushing it for anybody. Great, well, thanks so much. And my email's up there and I'm happy to answer questions later too.